There we go.
Hey, everybody. I'm Sandra Dixon. I'm Director of Behavioral Health Integration at LMH Health in Lawrence. A little bit about my background, how I come to this conversation. I may have met some of you in my old life. I've been at LMH in this role a little over 4 years. I'm a social worker by training. I have my master's in social work. I've been working in the field for 40 years. I just shudder every time I say that number. Before I was at LMH, I was Chief Clinical Officer at DECA, which is how I might know some of you all, overseeing all of their addiction prevention and treatment programs, mental health services, some of their child welfare service. I spent 8 years on the Governor's Behavioral Health Services Planning Council, and currently on the Kansas Fights Addiction Grant Review Board. So I was just chatting with Alice earlier. I have kept my little finger into the public behavioral health system, but after a really, really long time, I'm kind of glad to be just sitting in my home community in Lawrence, doing some really fun things. So I'm going to share with you today how we got to the point of starting collaborative care, and then some of our tools and resources that we've been using in our implementation of that. And I'm going to tell you some of the really cool things, and I'm going to tell you the learning we've had, which is my reframe of the things that we've learned that we shouldn't do. um, and so please ask questions. Hopefully this is interactive. Um, I I love this program. I am really excited about how it's helping our patients here in Lawrence. And so I will talk forever. So please like yell at me or something if you have a question. And I do want to leave plenty of time at the end. So I'm going to share my screen. All right. Alice, I just want to be sure everyone can see that.
I'm giving you a manual thumbs up.
Okay, good. I've got three screens happening here, so it might be that I don't respond right away. So you all know where Lawrence is, but a little bit about LMH Health. We are a freestanding nonprofit community-based hospital. We are not associated with the University of Kansas Health System or Advent or any of the other larger organizations. That's something that's very important to us. Um, we are founded by a woman named Elizabeth Miller Watkins. If you are a KU graduate, hopefully that means something to you. And there's just a commitment to serving people no matter their ability to pay, which you can imagine is pretty hard in healthcare right now. We have 174 beds. We don't use all of those beds, but that's what we're licensed for. We also have 28 clinics in this area. 10 of those are primary care, which includes family practice and internal medicine. And so we have about almost 2,300 people of various roles in the Lawrence area serving patients. And I'm a patient. I've been in Lawrence 28 years. I'm a patient. I've been a partner, and I'm really glad to be working here and doing something fairly innovative. So again, I came here a little more than 4 years ago. This is a brand new position. There was not a position called Behavioral Health Integration Director. And it was at the time when our local crisis center was being developed, the CCBHC process was being developed, and LMH was beginning to think about what is our role in serving our patients who have co-occurring behavioral health conditions, and how do we help move the needle a bit, either in collaboration with our partners or doing it on our own. And so I spent basically the first 8 months having been a close partner with LMH, but now kind of in behind the walls, talking about patient experience, which included long wait lists for psychiatry, long wait lists for therapy services, especially if they didn't have a payer source, talking to our providers, predominantly in primary care, um, frustrated about the wait list for patients to get into behavioral health service because not treating the behavioral health condition means their medical conditions aren't being treated well either. And if they were engaged, real challenges in coordination of care and communication to know what might be prescribed in the psychiatry office, what services are being provided so that they can help support that and vice versa. We had some significant financial considerations. I come from the nonprofit sector where there were lots of grants. There was block grant, a lot of Medicaid. You all certainly with your HRSA grants, and that is just not a thing here. And so, as providers were talking with me about what they wanted a psychiatrist in every clinic, and they wanted a licensed clinical social worker in every clinic. They kind of wanted to look like a federally qualified health clinic. And that's just not financially doable for an organization like ours. And so we really had to think about what could we do, either in collaboration or on our own, that was financially viable. And so we made four commitments. We wanted to ensure timely access. We did not want patients to have to wait a long time to get into care. We wanted to ensure there was good coordination of care so that the primary care providers knew what was happening with their patients, that they could talk with their colleagues to be able to coordinate care well. We wanted it to be evidence-based. So I always have these great ideas about things we could do, but there's not a lot of research behind them. So we wanted something that we knew had shown good outcomes for patients in other parts of the country, and then it had to be financially viable. So those were the commitments that we made. And so in December of 2023, we landed on the idea of doing collaborative care. Some of you may be familiar with Verna Little at Concert Health and other kind of founding folks related to collaborative care, the Ames Center at the University of Washington. So we spent quite a bit of time talking to lots of folks and really felt like that this model would be something that we could do. And little did we know that how difficult it might be to be the first entity to implement this in Kansas from a payer perspective. But we were pretty committed. So you all have seen this, I'm sure, in your work. This comes from the University of Washington Ames Center website, the kind of the four different pieces of collaborative care. And I'm going to share with you how we have implemented this and some of our tools that we're using. And any of this I'm sharing with you, feel free to talk to others and replicate because none of this is super secret. So I'm going to start with a primary care provider. So our referral criteria currently is anyone 18 or older. There is evidence that says collaborative care is very effective with pediatrics and adolescents, but we have not yet gone into the conversation about parental or guardian involvement and consent. So we are looking at folks 18 or older. They have to be established at LMH. So primary care is where we started in 2024. We have just recently expanded to our OBGYN clinic. They have to be currently experiencing moderate depression or anxiety symptoms. We're not asking our primary care offices to do the PHQ or the GAD, although we do universal depression screening. Our team will do that. But we talk to providers about if they don't already have a depression or anxiety diagnosis, what are you seeing in your patient? Are you seeing sleep disturbance? Are you seeing racing thoughts? Are you seeing eating disturbance? Any of those symptoms of depression or anxiety, is the patient telling you that their functioning is decreasing? So we've given our providers just a list of things. If you're concerned about these or your patient's talking about these, maybe it's a good referral to collaborative care. There has to be, CMS requires depression or anxiety diagnosis, and it could be a presumptive diagnosis. We see a lot of anxiety disorder unspecified, depression disorder unspecified, and we will help providers kind of work through what that final diagnosis might be as we work through the process. And then this is voluntary, and CMS requires that the patient give consent. So these are all the things that we are thinking about when we are looking at a referral. So the LMH provider's role, and this has been the heaviest lift for us in implementation. Again, our providers were really committed to referring out to more psychiatry and referring out to more therapy versus managing this case from a behavioral health perspective. So we've spent a lot of time with them about how we talk about collaborative care, how we talk with the patient about why this brief intervention might be something that could benefit them. And if the patient gives verbal consent to yes, you can make the referral. They're not yet consenting to the service, but they're saying, okay, you can make the referral. CMS has some very specific guidelines for what has to be in that provider note. And so we try to make everything easy for our providers. And so we created what we call a dot phrase in our EMR, and all they have to do is pull it over so that we have verification that they talked to the patient and the patient gave consent for the referral. We use Oracle Cerner for our medical record. And so within that system, there's a referral management functionality that they're putting the referral in referral management. And that is part of the way we track progress through collaborative care is through that system. And there has to be a depression or anxiety diagnosis attached to that referral. So when my team gets the referral, if they don't see the diagnosis and they don't see the dot phrase, they're communicating back to the provider to amend their document to ensure those things are there. The biggest lift for us, again, has been the primary care physicians prescribing medications versus referring out to prescribe those medications. So I'm going to talk a little bit more about that here in a second when I talk about psychiatric consultation. And then they're monitoring progress. One of our commitments was to coordinate care well. And so they hear a lot of information through the medical record messaging center, updates on their patients, what's happening with the medications and side effects so that they're aware of what's going on with their patient. So that's their role. One of the things that they asked me for early on was they literally said to me, tell me exactly what I need to say about collaborative care when I'm meeting with the patient. So we put that together for them, and then they changed it to put it in their words and what they thought their patients might resonate with better. And so we have these cards. This is one of the tools we use. They're recipe size cards that are sitting in all the exam rooms. And the provider or the nurse can just pull it out and say, hey, we've got this service. It's part of your clinic experience with us. Here's what you might expect. And that way the patient can take it with them. Maybe they want to think about it. Or if they say yes to the referral, at least they have a piece of information when my team calls them for the first time. So it was really important to the providers that they not have to be responsible for understanding everything about this service and that they could clearly articulate what it was. And as we've gone along, we've been at this almost 2 years now. We have some providers who've changed this up a bit in their clinics based on their experience with collaborative care, which has really been effective. So one of the things that Alice asked me to talk about was our registry, which is one of the 4 required elements of collaborative care. And I would tell you there's not really an easy way to do this. It's a little cumbersome. But as we were vetting this, we started talking to the Amwell Corporation, who at the time was doing quite a bit of collaborative care work. And so what I have for you here is a portion of the registry that we purchased via contract from them. So what this looks like in real time is a very long Excel spreadsheet, but I didn't want to put a very long Excel spreadsheet up on the screen. So I just kind of blocked it. Silver Cloud is something that we can invite patients to within our medical record. There's a module that if they consent to collaborative care, we invite them to Silver Cloud. It sends them an email or a text message and they can log in. But the functionality sits outside of our medical record. So our team is looking at 2 different systems. But in the registry piece, all the demographic information, so we have name, date of birth, race, ethnicity, birth sex, administrative sex, and some other demographic information that pulls over from the medical record. I just didn't put that up here for you. But you'll see in this registry that their ID in Silver Cloud is different than their ID in our medical record. That's an Amwell thing. You can see their status. So this first patient example, they are currently working in Silver Cloud. The second patient is pending. They've been invited, but have not yet accepted the invite. I'm going to tell you here in a minute what program means. And then we have all of our dates. So one of the things that my team will do is review progress in Silver Cloud. That's where we do all of our PHQ and GAD screening in the registry. So you can see their first PHQ-9 score, every 30 days is when we screen. Their last PHQ-9 and GAD-7 scores. You can see in the second line, this is number of logins. One of the functionalities within Silver Cloud are CBT modules, which I'm going to show you in a minute. And we can see how many times the patient logged in. So for this first patient who's been with us since June 1st, they've logged in 57 times and they spent a total of 46,000 seconds. I don't know why Amwell chose seconds, but they did. Um, I can see how many times under review, how many times my team went in and looked at the information for their patients. Again, the PHQ-9 and the GAD information. I can see if the patient needs a psychiatric consultation. I can see, are they choosing not to use the CBT modules? I'm going to show you here in a minute. I can see payer. I can see if a relapse plan has been developed. So all of this information is available in our registry that we can then pull down and create reports. So one of the reasons we chose this product instead of developing our own was we wanted something that we could also give to patients that they could use without us present. So if you're familiar with MyStrength, for example, it's an online application for specific topics that has didactic information, it has videos, it has interactive and journaling, and Silver Cloud is the same way. So when we invite someone to Silver Cloud when they enroll, we sign them up for one of these modules. Typically, it's the one that says Space from Depression and Anxiety. That one contains about 15 different modules on various topics. In the intake appointment, the team is always pointing them to one specific place to start and giving them some handouts. As good CBT folks, we're going to give them something to do from the very get-go. And then the patient can work through these modules on their own. My team can look at the progress in their modules. I'm going to show you how the patient gives feedback about these modules. But what we really liked about this, in addition to having the registry already built, is that the patient has access to this for 12 months after they leave collaborative care. So it's a tool that they can take with them. And what we tell patients is you're going to have really good interaction with the social workers on my team, but you're also going to be creating your toolbox that you can use the tools to manage your depression and anxiety when we're done. And you're going to have access to the information for 12 months. So that was one of the selling points for us for choosing this as our registry and not building our own or using the one that you can purchase from the University of Washington Ames Center. So before I keep going, Alice, are there questions about provider or registry in the chat?
There are not,
Okay.
but maybe a pause here and see if anybody has any questions. They want to come off mute.
I do have a quick question. Is the Silver Cloud and Amwell, are those two interconnected or were those two separate things?
Yeah,
Sorry.
Amwell is the corporation, Silver Cloud is the product.
Got it. Got it. Okay. Yeah, no, this is super interesting and helpful for us. So I'm loving it. Thank you.
And from a cost perspective, we pay $65 per license. So every time we sign somebody up, it's $65, which for the patient, that we don't charge the patient, but I mean, that's not bad, but we had to purchase licenses in bulk. So if we don't use them, we're paying for them anyway. So that was a lot of our upfront cost.
And Sandra, is that $65 for the 12 months?
Yep, that's $65 for the patient for the duration the patient has it.
Okay, thank you.
So the other thing Alice asked me to talk specifically about was how we use the psychiatric consultation. And I said to Alice and Mel before you all get on that by Thursday, my filter tends to be gone. So I'm going to tell you how we chose this. Um, so we have 2.5 FTE psychiatric providers at LMH. They're all clinic-based. And our original plan was we would allocate time from one of them to be the psychiatric consultant, and they were not having it. When we were planning this and developing this, they did not see the value in consulting and someone else prescribing. At one point, one of our providers said the only folks who would benefit from collaborative care, and this is a quote I've kept with me, it just motivates me every single day, are soccer moms who need some medication to get by, which I was not happy about, but um, they've since changed their tune. I'll tell you about that in a little bit. So we have contracted with another company to provide the psychiatric consultation. Our psychiatric consultant actually lives in Florida. She's a physician level. We have a contract for 16 hours a week with her. She is Kansas licensed. She's certified on our medical staff, so she is part of our team. And she is amazing. She had not been part of collaborative care until they contracted her with us, but she really has become an invested part of our team. And so, how this works with us, she does weekly case consultation with my team. They meet Wednesday mornings at 9. On Thursday afternoons, the week prior, my team sends to her the list of patients that they would like her to review. And we do it in this priority order. Newly enrolled patients, we have a metric that we want patients to be reviewed by the psychiatrist within 14 days of enrollment, because the sooner, if medications are appropriate, the sooner we start those, the better. The next is patients who are projected for discharge, whether they are successfully completing, there's been a lack of engagement. So that's the next priority. And we always do a mid-service review. Currently, our average length of stay is 4.5 months. And so at about month 2, she is reviewing, again, patients she reviewed at enrollment. By then, they've been on medication, if that was appropriate, 30 days or more. And so we've gotten past the first couple weeks to see what the medication side effects might be. And so she's reviewing them then. She will also help the team review patients who just aren't progressing. And one of the real values that she has provided to us is not just making medication recommendations, but really thinking about course of treatment. Do they need a higher level of care? So she's really doing case supervision as well. And then we have a process called request for inclusion. We have not done this yet in the almost 2 years, but we have some pretty significant referral criteria. So someone with schizoaffective disorder is not someone we would typically see. We don't see a lot of patients with bipolar disorder where mania is prevalent. But our provider could say to me, you know what, I know it's outside the scope of the referral criteria, but I really think that this patient would benefit. And so we have an opportunity for that, for our provider to say to me and to the psychiatrist, we really think you should consider this. We haven't had to do that yet, but that's also an option. So I'm going to show you kind of what this looks like, the tool we use.
Sandra, I
So
have a question on those meetings.
yeah.
Typically, how many patients are being reviewed each week?
Well, so this example that I'm showing you
Okay.
is probably on the lower side. Um, we've had a run of referrals recently and increases in enrollment. So sometimes they're doing 16 to 20 on a Wednesday morning. We are talking about adding, we also have contracted time on Friday with her. And so we're talking about adding another time for her to meet with the team. They only spend an hour and they're able to get through most of these. But once we get more than 20, we're probably going to need another time because our acuity level is not soccer mom. Our acuity level has gotten pretty high, so they want to spend some quality time.
Thank
So
you.
this is what my team will send her on a Thursday evening so that she can review the medical records on Friday. I've taken the identifying information out, but we have them in the 3 buckets. The EMR number would be here, so she could easily access the Cerner record. And then they're providing just kind of a little snippet of what some of their questions are. So she goes in, she reviews the record. When they meet on Wednesdays, they talk through them, and then she puts a psychiatric consultation note in the medical record so that the primary care provider can then read that if they choose to. My team will share with our provider what the recommendations were. We never talk to the patient first. We always go to the provider. The provider might say yes or no. They might say, I want to talk with the patient first, or they might say, heck no, I am not prescribing that medication. So we want all that negotiation and recommendation work to happen before we're going to the patient. And our psychiatric consultant is very open to talking directly with the providers if they're concerned about a recommendation. And she almost always has a second or third backup plan if they're not comfortable with the initial medication. One of the things we started doing about 7 or 8 months ago is, again, prescribing the psychotropic medications was not something that our primary care providers, especially the family practice providers, were really excited about. So she put together a list for me of what she typically recommends so that they might know what to expect. And that really helped them kind of calm their concerns about prescribing medications. It was important for our providers to see that she rarely prescribes benzodiazepines. She more often will prescribe hydroxyzine for anxiety. So they really resonated with that because a lot of our practitioners don't like to prescribe controlled substances. So this has been really helpful. This is something I start with now in orientation with new providers because this is the issue that causes providers not to refer, is prescribing these medications. Okay, so I'm going to stop. Any questions or additional information about the psychiatric consultant piece? So here's what I would tell you about our psychiatric team. When they started with, it should only be soccer moms who need medication. What they will tell me now is that when we are bridging patients who've been in collaborative care for a little bit and we are bridging them to long-term psychiatry, that the patient has some realistic expectations about what medications can and cannot do for them. They have already gone through that kind of trial period. If one medication isn't working or one dose isn't working, they've already kind of gotten that leveled out. And that the patient is ready to work in psychiatry or work in therapy because they've gone through that period of, well, I don't know what I need to work on to help myself feel better. And now they've figured it out with collaborative care. So our physician, who made the soccer mom comment, has now said they're more effective patients and ready to work than we've ever had before. So for me, that's a win. The most important piece of this puzzle for me is what we call our behavioral health navigator. In the literature, you'll see them as behavioral health case manager, maybe some other language. Our providers were really clear. They wanted the word navigator. They had some PTSD about chronic case management. So I have 2 full-time master's level licensed social workers. One of them is clinically licensed. I also have a PRN, master's level social worker. They are based out in the clinics. Typically, the intake appointment is in person in the patient's clinic, so it's a familiar setting. Everything else after that, if they enroll, is virtual. So we have a virtual product within the EMR that's similar to Zoom or is on the phone. It can also be asynchronous. So within SilverCloud, there's a messaging system. So whatever works for the patient, that's how they're communicating with the patient. They respond to the referral within 24 to 48 hours. Again, access is important. Typically, we can reach the patient pretty quickly, and then that intake appointment is scheduled a few days later. They are facilitating the behavioral health screening. So in the intake appointment, they're doing the first PHQ and GAD-7 to determine kind of where they are on those scales. And then all the rest of those screenings happen in SilverCloud. They're also doing the MDQ. If we are concerned about bipolar, they will use that screen. We've been spending a lot of time focusing on patients who are referred for anxiety concerns and trying to determine, is it anxiety? Is it trauma? So we recently implemented the primary care PTSD-5, which came out of the VA system to really assess for trauma. And then my team is not as versed in the substance use treatment world, but it's something that we all know that a lot of times these things are happening on a co-occurring basis. So we're beginning to implement some SUD screening for patients that we are concerned about. So they're doing all of that screening. In the first month to 6 weeks, it's weekly brief interaction. The intake appointment's usually an hour. After that, 15 to 20 minutes, sometimes less. If the patient's making progress, they'll go to every other week. Again, it's virtual or asynchronous. And they're talking with the patients about, symptoms and side effects of medications. One of the real helpful things that they're doing is, patients aren't always willing to wait to see if medication takes effect. And so the navigators can really say, okay, it's going to take a couple weeks. What kind of things can we do during that time period to help you manage the symptoms? When patients are working in Silver Cloud, the team will help them implement some of those skills. Again, a good CBT process of implement this, come back and tell me how it went, let's tweak it. They're using motivational interviewing, behavioral activation. We do have a pretty high acuity in some of our patients, and so there is some therapeutic, what you might consider a traditional therapeutic intervention. But we're really clear, this is not long-term therapy. This is 3 to 6 months, but they are using therapeutic skill. They are the communication hub. So they're talking to the site consultant, they're talking to the provider. We're screening for health-related social needs using the prepare form. And if they have those needs, the team is helping them work through resources for those. And then one of the things that we learned really quickly is because our acuity is high, and sometimes patients really do need long-term psychiatry and therapy. We're going to tangibly work with our community-based providers or our internal psychiatry providers to get patients connected. So instead of, you probably should go to therapy, here's the list of therapists, or call your insurance provider. My team is actively working with the patient to identify that next provider and ensure that they have that intake appointment before we let them go. We want to know that they're established. So we have about 20% of our patients where that's happening very formally, so they don't technically complete collaborative care, but we have bridged them to the next community service. That's been very helpful for our providers to know that we're not just sending patients out when we're done with them, that they're actually getting connected to people. And again, our psychiatric providers are saying they are ready to work when they get to us.
Sandra, there was a question in the chat
Yeah.
about the navigators and if they ever meet in person.
So they will meet in person, typically with the intake appointment, because we want that face-to-face connection so they can help develop the relationship and rapport with the patient. But because they travel around and because we want to make this convenient for the patient, unless the patient really needs it, and we have a few, everything after the intake appointment is virtual or asynchronous. Because we have clinics, I don't know if you're familiar with the Lawrence area, but we have clinics in Tonganoxie and McLeod, which is about 30 minutes north of here. We have a clinic in Baldwin, which is 20 minutes south, and then a clinic in Eudora. So if they had to see patients in person all the time, our caseloads would have to be really small because they'd be traveling around a lot. And our patients really seem to like the fact that it can be virtual or asynchronous.
Thank you.
Sandra,
Yeah.
while we're asking questions, are all of your 28 clinics participating in the collaborative care model?
So we have 10 primary care clinics, and we're currently also in our OB office. So the others are cardiology, oncology, ortho, Kansas. We hope to expand to our oncology clinic next, but we started with primary care. And I think we've had referrals from everybody at this point, some only one or two. And we do have providers who say, heck no, I'm not doing this, but I'm going to show you what we share with them anyway to kind of encourage that. But I would say probably 50% of our primary care providers refer on a regular basis.
Okay, great, thank you. And my other question was going to be how many of your providers in the clinics where you're practicing the collaborative care model are engaged in the collaborative care model?
It's about 50%.
Okay, great, thank you.
I'm assuming you all know how the financing works, and I'm watching time here. You all know how the financing works. We have to have documented time related to these specific activities to reach that 70-minute in the first month, 60-minute in the subsequent months, and then the additional time that we can charge for. We made a decision that even if we spent 150 minutes in a subsequent month, we were going to only add that extra 30-minute code once because copays apply, and we didn't want to financially burden our staff or our patients. So one of the challenges with collaborative care is the time documentation is really, really specific. You have to be able to match the time you spend with your documentation. So I'm going to show you how we did that. This is a screenshot from Cerner. And you'll see each of the allowable activities on the left and total time in minutes on the right. When we started, they had to put in start and stop times, which you can imagine social workers, like that's not a happening thing. So we kind of pushed back on what we were told regulations were, and now it's just total time. When we started, each one of these things, if in a given day they had a face-to-face visit, they had the psychiatric consultation, and they were reviewing the registry, that meant 3 different of these documents, 3 different progress notes. And so we realigned, and now it's 1 per day. And what this does for us, this document populates our billing information. So every time in real time. So every time they're doing one of these documents and they have a corresponding progress note, it feeds into our billing document. So at the end of the month, we can see really clearly, do we have enough time per patient? And I run this mid-month so that they can see where they are with their patients midway through the month. This is also where we document program completion or ending so that the encounter stops. And this has been really helpful to the team. They don't have to manually kind of end date a patient. So this is where we landed. It's not the best thing in the world, but it's easier than when we started. The recommendation coming from some of our consultants was to do it on an Excel spreadsheet, and that was not going to happen. So we created this.
Sandra, just for clarification, the billing provider is the primary care provider?
Correct.
Okay.
But it's the time associated with documentation from the navigator that counts.
Perfect. Thank you.
So here's what we're measuring. Again, this is my favorite part. So when we started, we were the first, and not everybody and all payers were paying for collaborative care. And so we had to go to the largest payer in Kansas and negotiate an agreement that they would do this with us, but they wanted to see some specific data. And so we look at every quarter discharge patients in these 3 timeframes. Patients who've been with us at least 30 days, patients who've been with us at least 90 days, and then a subset, patients who complete. So all discharge patients and then patients who complete. And we are looking at, for each of those 3 cohorts, did they have a 5-point improvement on their screens? Did they have a 50% or 10-point improvement on their screens? And from the research perspective, 50% is considered clinically significant improvement, and that's our threshold for program completion. And then are they in remission, which is defined as 5 or less on the GAD and the PHQ. So where we are at the end of last quarter with March 31st, we're just now working with the second quarter data, but through March 31st, for program completion, 74% were showing a 50% improvement or better on the GAD-7, and 67% were showing a 50% or better improvement on the PHQ-9. And about those same percentages were in active remission. So we're really pleased about that. If they stay with us, they're using the modules, they're using medication, they complete, it's a high likelihood that they're going to see a 50% improvement in their symptoms. To date, we're at a 78% successful completion rate. So that's a lot of our patients who are feeling better, taking better care of their health outcomes. And so we're really, really pleased by that. I hope it continues. We're also measuring some metrics. So we know that the more touches, according to the research, the more touches you have with a patient, the more likely they are to be successful. So we're measuring the percentage of patients with 2 or more connections with the navigators. In the first 30 days, we're at 97%. We know if we get medication started early, the better that is for the patient. And so we want that psychiatric consultation within 14 days. We're at 90% for that. Again, we are using the GAD and the PHQ-9 to measure progress. And so we want to know how many patients are completing 2 or more in the first 90 days. And we're about 78% of that. We're measuring SDOH at baseline. Not many of our patients have an identified social need, but if they do, we want to know if they have that same social need when they discharge. And then median time to completion for us is 4.5 months. And interestingly, on the financial side, if a patient stays with us 4 months, that's when we begin to see a positive margin in collaborative care. So the financial piece and the clinical piece really do line up here. So here are the pretty things that I like to show. In the registry, the screens happen in the registry. What I can show our providers, even those who don't refer, people like you, and our patients. The top line is baseline GAD-7 screening. So entry into the system, where are they? And I tell people, just look at the color. On the right, it's orange, that's severe anxiety. On the left, the purple is mild to no anxiety. And so the top line is baseline. For these same 188 patients, they've had a second, at least one more screening, so 30, 60 days. You can see how the colors change. So we can show providers and patients, and I've shown leadership, and obviously I'm showing all of you, patients who engage in collaborative care and stay with it and work with us, you can see the improvement, even in just 30 days. So here's the same for depression. Again, we're looking at color. Far to the right is severe depression. Far to the left is mild to no depression. And after 30 days, you can see progress. So this is why, one of the reasons why I chose this registry, because it's not often in real time, you can show this information. And this is what has helped some of our new primary care providers coming on board really buy in. Because if they hear me say, it doesn't work for everybody, but when they work, it really does make a difference. We can also measure patient satisfaction. So within SilverCloud, every time a patient completes one of those CBT modules, they can tell us, was it interesting? Was it relevant to them? Was it helpful? And did it help them make progress? And again, we're looking at color. You can see over 1,400 responses and a 96% satisfaction rate. So when I talk to providers, it's really important for me to be able to share the story and the outcomes to say, if you refer and the patient engages, it's going to make a difference. So my final slide is some of the things we've learned, and then I want to open it up for questions. We take a real quality improvement approach here. Like, who are the patients who are not enrolling after referral, and who are the patients who are not completing? And what we've learned over the past almost 18 months is patients referred with an anxiety disorder are less likely to engage than those with a depression diagnosis, which kind of makes sense, right? Folks who are experiencing anxiety get easily overwhelmed. And so we're talking about how in that very first phone call to see if they're interested, do we acknowledge that this could be overwhelming, that it's one more thing to do, and how this might be helpful to manage everything else that they're overwhelmed about. The same is true. They are less likely to complete. And so again, we're really focusing on understanding whether it's anxiety or trauma. And if it's trauma, how can we help them manage symptoms through collaborative care while we're getting them connected to ongoing trauma care? And then we want to know the long-term impact. It's one thing to have really good outcomes in the moment, but fairly soon, we're going to start measuring, before they came to us in collaborative care, how much were they and we spending on their health care? How much activity was there in their health care? And then 6 months after discharge and a year after discharge, what are we learning about their health outcomes and what are we learning about cost? Because what we really want to see is that the investment in collaborative care is reducing not only our healthcare costs, but the patient's healthcare costs and improving their health outcomes. So they should, in theory, should be able to manage their other chronic medical conditions more effectively if they've got the tools they need to help them manage depression and anxiety. So I'm going to stop sharing. Interested in what questions? Okay, hold on.
Yep, we do have one question that's come up in the registry. If a patient is enrolled, discharged, and re-enrolled later in the same year, is that $65 license paid again?
Yes. So it's
Okay.
by enrollment.
Okay.
And CMS says if the patient comes back within the original 6 months, so they were with us for 2 months, they go away for a month, and then they come back in month 4, that's still considered the same encounter. So we don't start over from a billing perspective, but it's a new license. And then if they come back after 6 months from discharge, then it's a new enrollment.
How often does that happen?
So we've had a couple situations where we have some military folks, so they had to go somewhere for a minute and then come back. We've had 3 patients that I know of who are some of our early patients who have come back to us recently, but their entry-level scores were less than they were when they started the first time. So we know these are chronic conditions. So
Sure.
it's not out of the question that they might come back to us for a boost.
Yeah.
Um,
But
financially,
it sounds like it's not the norm for that to happen.
no, it is not the norm.
Yeah.
So financially, some of the things that we were really committed to, we are fortunate to have a foundation. And when we started, Medicaid wasn't paying for this yet. And we have folks who are self-pay. We have folks on the ACA plans that, are just getting worse by the minute. And so our foundation covers the cost of people who would otherwise not be able to pay. And then I was sharing with Alice and Mel earlier, for those of you who see TRICARE patients, as of last week, TRICARE is not reimbursing for collaborative care. So we're using foundation funding for that if they can't afford to pay.
So we'll open it up. If anybody wants to come off mute and ask your question, please feel free to do so. And I know this is not a shy group.
So I am going to send this PowerPoint and PDF version to Alice. It has my email on it if you ever want to ask questions on the side. I'm also going to include in that, I'm assuming you all are familiar with the University of Washington Ames Center website, which is kind of the go-to for setting up collaborative care. I'm going to send that. And then there's another, thank you for that feedback. I would be open to, you can come visit anytime. Coming to Lawrence is not a bad thing to do.
She has alternative reasons.
Okay, well, whatever works, right?
I'm just kidding with you, Chris Ann.
There's another organization up in Minnesota who also has website-based resources and training resources for navigators, site consultants, and providers. So I will send those links along as well.
Great. Well, Sandra, again, thank you for taking the time to visit with this group. They're doing some amazing work as they're learning this model and implementing this model. And, I think some of our continued challenges still are around the workflows and the billing piece of it. And I'm confident that they'll get there. They'll definitely get there. And there's lots of great support out there to help guide us through this work.
Well, again, thanks for including me. And anytime you all have questions about any of those things, if I can't answer, I'll connect you to our internal folks. Because I think what we've learned about doing this is almost as important about what we're actually doing.
Mm-hmm. Yeah. All right, one more opportunity for questions. Getting a lot of thank yous
Appreciate
in
y'all.
the chat, so yeah. Well, thank you guys for taking the time to come today. I know it's something that has been asked for, and we're glad we were able to make it happen relatively quickly for you all. So I'm sure we all have calls with our KDADS partners coming up here in the near future. And so feel free to reach out to any of us for any support, and we'll get the information shared with you along with the recording of this presentation as well. We'll get that shared too.
Great. Thanks, y'all. Take care.
Thank you.
Thank you so much, Sandra.
Thank you.